I'm Brad Gonzalez, cardiac surgeon and intensivist, and I'd like to review the use of the modular endOclear Liberator airway maintenance system. Any patient who is intubated and brought into the ICU is connected initially to the endOclear closed suction system, which is a modular system that starts with this manifold. There's this double swivel. Additionally, there is a stopcock that completely isolates the ventilator circuit from any module that is subsequently attached to the manifold. Initially, the closed suction module is connected. It can be either 12 or 14 French. There is a 180-degree lock controller, a wedge for removing the endotracheal tube in times where it would be stuck and would need to be removed, and the other feature is a gown clip that we can use for early ambulation of the intubated patients. When the patient requires suctioning, the stopcock is turned and the suction catheter is advanced, and if shallow suctioning is done, the markings of the suction catheter are lined up with those on the endotracheal tube. In cases where deeper suctioning may be required on clinical basis, obviously we can then suction more deeply into the lung. The suction is deployed, pulled back into the cleaning garage, and the stopcock then turned to close off the module from the manifold. At this point, additional suction passes could certainly be made. Once the clinician is satisfied, we recommend 15 cc bullets because of the additional volume of cleaning. The cleaning garage is elevated slightly so that the suction holes are in a dependent position, and the saline is squeezed while suction is being applied to the cleaning garage, and this is done until the catheter is visibly clean. In patients that require additional maintenance of the endotracheal tube by removing the secretions that closed suction invariably leaves behind, we have the Liberator module that will need to be attached to the manifold. The Liberator catheter has a sterile cap. The catheter itself is somewhat different than closed suction in that we can deploy the wiper and then pull it back through the endotracheal tube in order to remove the retained secretions. When the arrow points to the ISO standard for lock, neither the suction nor the wiper can be deployed. When the arrow lines up on the balloon can be deployed, but the suction doesn't work. And when we're on suction, the suction works, but the balloon cannot be deployed. When it's turned back to lock, neither functions. When the Liberator is required to be used, the sterile cap is removed. It's placed on the closed suction system, which is then placed on the working area of the patient in bed. The Liberator module is connected. I usually move this to get it a little bit out of the way for advancing the catheter. The stopcock is opened, and because the catheter is silicone and not as firm as the suction catheter, the way this is advanced is to advance the catheter and to gather the sheath onto this area, which is a small plastic tube, and you can gather the sheath as you advance. The initial time the Liberator is used, the centimeter markings are lined up with those on the endotracheal tube. And once those are lined up, we know that the wiper is positioned appropriately. At that time, we also look in the cleaning garage window and are able to see a centimeter marking, which in this case says 38. What can subsequently be done is that every other time this device is used, the catheter can be inserted up to the 38 in this window and know that it's in the correct position distally. Once that's been done, the control is turned to wiper, and with a patient inspiration or a ventilator inspiration, the wiper is deployed and pulled back into the cleaning garage, and the stopcock is closed. At this point, the cleaning procedure is done by moving the control to suction. The 15 milliliter saline bullet is placed. The manifold is elevated slightly so that the suction holes are dependent, and suction is applied, and the saline is rinsed, and all of the material that has been accumulated from the tube will then go into the suction and into the wall waste. Once that's been done to visually clean, the device can be put back to lock, and the closed suction can be reconnected. The sterile cap goes on the 72-hour Liberator device, which is then stored offline in a storage bag that says endOclear. You're able to see what device is inside and in fact read all the numbers, including the 72-hour sticker that would be placed right here on the suction control. And there is a hole in the bag so that it can be hung up on the ventilator or with the oral care or in any convenient hanger in close proximity to the patient or where it would be used. So, in the event that the material inside the cleaning garage is so tenacious, bloody, etc., that the catheter can't be cleaned, the other advantage of the modular system is that it can be disconnected, the catheter advanced, and a sterile 4x4 can be used to physically clean the catheter and then reconnect it to the manifold. This can help potentially save a catheter for its full 72 hours of use. Intubated patients sometimes require instrumentation of their airways, either for bronchoalveolar lavage or bronchoscopy while in the ICU. This is the endOclear bronchoscopy adapter that works with the endOclear Liberator airway maintenance system. The bronchoscopy adapter is also a modular component of the system. It has a flexible diaphragm that accommodates size instruments between 3 and 8 millimeters, and once the instrument is inserted, it is air tight to 40 centimeters of water pressure. It comes with a sterile cap and when the patient requires bronchoscopy, first we know that the stopcock is closed. This means that the ventilator circuit will not be compromised so that we can do these types of procedures even on patients with ARDS that have very high oxygen requirements and high PEEP, for example. So the sterile cap is removed. Once again, the closed suction is disconnected and placed on the working area, and the bronchoscopic adapter is placed. The instrument is inserted into the adapter and the stopcock is opened. Subsequently, the procedure is done, and once the bronchoscopy or BAL has been completed, the bronchoscope is brought back into the adapter, and once again the circuit is reestablished. At this point, the adapter can be disconnected, the bronchoscope sent away, or if desired, the scope itself can be cleaned within the cleaning garage by using the 15 cc bullet. If this were a BAL catheter, one could get additional specimen by flushing and suctioning through the catheter itself before disconnection. Once the disconnection is made, the closed suction is reconnected to the manifold, and through all of that, no ventilatory function was lost.